Greetings, everyone, and welcome to the final event in our inaugural Fall Symposium series, the Veteran and Family Wellbeing Series, a person-centered, evidence-based approach to chronic pain. Bonjour tout le monde et bienvenue au dernier événement de notre série inaugurale de Symposium de l'automne. Série sur le bien-être des vétérans et de leurs familles, une approche de gestion de la douleur chronique basée sur les données probantes et centrée sur la personne. I am Dr. Ramesh Zacharias, Chief Executive Officer and Medical Director for the Chronic Pain Center of Excellence. At the Center of Excellence, our mission is to improve the well-being of our Canadian Armed Forces veterans and their families suffering from chronic pain. Je suis le Dr. Ramesh Zacharias, chef de la direction et directeur médical du Centre d'Excellence sur la douleur chronique. Au Centre d'Excellence, notre mission est d'améliorer le bien-être des vétérans de nos forces armées canadiennes souffrant de douleurs chroniques et de leurs familles. Merci à tous de vous joindre à nous aujourd'hui. Maintenant, je vais laisser la parole à nos modérateurs, le général Eric B. Schoolmaker et General Michel Maisonneuve. Thank you all for joining us today. I will now pass it over to our moderators, General Eric B. Schoolmaker and General Michel Maisonneuve.
Thank you, Dr. Zacharias. We are privileged again to open our session with a special guest.
Hey everyone, Aaron Ekblad here from the Florida Panthers. I'm honored to be a part of today's event led by the Chronic Pain Center of Excellence in collaboration with the U.S. Department of Veterans Affairs and the U.S. Department of Defense. As a hockey player and an athlete, we all experience chronic pain to some degree. I work hard every day to manage both my mental and physical game so that I can overcome obstacles and continue to get better, with the ultimate goal of extending my career and living a longer, happier, healthier life. As a proud Canadian, I've been fortunate enough to grow up and live in a country with all the freedoms and opportunities in the world. And it's because of the commitment and service of our veterans that I'm able to play the game I love every day. Thank you very much for your service.
Bonjour, chers amis. Mon nom est Michel Maisonneuve et je suis un vétéran de l'armée canadienne dans laquelle j'ai passé 35 années. Je suis honoré aujourd'hui avec mon collègue, le lieutenant-général Schoolmaker, de servir comme modérateur de ce dernier dans notre série de 4 webinaires. Since I removed my uniform in 2007, I've tried to give back to all those who supported me throughout my career by helping veterans of all ages. Over my 35 years in uniform, I realized that chronic pain is a constant in the lives of many sailors, soldiers, and airmen and women, and for many, this pain follows them into retirement. So it's my honor today, alongside my colleague, Lieutenant General Schoolmaker, to help moderate this last of our 4 webinars dedicated to helping veterans who suffer from chronic pain. Je vous demande, si vous ne l'avez pas déjà fait, de vous inscrire dans le panneau à droite et vous pouvez poser vos questions de la même manière. Ensuite, il est plus facile de visionner le webinaire en mode plein écran. Pour voir les sous-titres en français, il suffit d'activer le mode Closed Captioning ou sous-titrage codé. C'est l'icône CC au bas de votre écran. Je passe maintenant la parole au lieutenant-général Schoolmaker. À vous, Eric.
Thank you, Michelle. Good morning and welcome to this very special webinar aimed at sharing our collective experience and our wisdom and many questions about how to provide the best care for our Canadian and U.S. service members, our veterans and families with chronic pain of all eras. I want to begin as well thanking Dr. Ramesh Zacharias and his colleagues at the Chronic Pain Center of Excellence at McMaster University for the invitation to be with you today and for the Wasserman team in producing this series. And again, a shout out to our special guests in the National Hockey League who remind us that our professional and other athletes carry always a major burden of pain through which they must work to achieve optimal function. And their support for this whole series has been much appreciated. I am Lieutenant General and Dr. Eric Skumaker. As my colleague, Lieutenant General Massanouf described, I was privileged to serve in the U.S. military for over 3 decades, culminating as the United States Army Surgeon General and Commanding General of the Army's Medical Command. I, too, have a passion for helping those who are suffering with pain, who have served in uniform in protecting our 2 nations through generations. I'm privileged to serve as a co-moderator for today's unique international forum. This is the last, regrettably, of our 4-part series, sponsored by the Chronic Pain Center of Excellence. You can best join us by signing up on our website. You can ask questions via the information block in the right-hand side of your screen. Please view us in the full screen mode. And if you're one of our French-speaking audience, we urge you to use the closed captions that are available for you. I'd like now to introduce 2 remarkable leaders in pain within the United States, both in the VA as well as in the Department of Defense. You've met them before, but I will introduce them again. The first, it's my privilege and a pleasure to introduce the Executive Director of the U.S. Veterans Health Administration's Office of Patient-Centered Care and Cultural Transformation. That's quite a mouthful. Dr. Ben Kligler. Dr. Kligler, a physician by training and a primary care doctor, has been a career-long supporter of whole health and pain management. He's going to speak today on an expansion of what he described earlier in our series by describing the outcomes that we're seeing in applying a much more holistic, multi-dimensional and team-based approach that is centered on patient care, on patients' needs rather. I also want to introduce Dr. Friedhelm Sandbrink. He's the National Program Director for Comprehensive Pain Management and Opioid Safety at the United States Veterans Administration. He's been an innovative clinical leader. He's a champion for the step care model of care, which among other ideas and outcome measures he will be describing today. Dr. Kligler and Dr. Sandbrink, the podium is yours.
Thank you, Eric. And Friedhelm and I are very happy to be back again to continue the conversation with you all about incorporating the biopsychosocial model and whole health into the treatment of pain and some of the lessons we're learning in the VA. I'm going to share some of those lessons with you and then pass it back to Friedhelm for a bit more about how we integrate into pain care. So just as a reminder from last time, the whole health system, which is how we're delivering the concept of whole health, is spreading across the VA. The definition of whole health that we use is whole health as an approach to healthcare that empowers and equips people to take charge of their health and well-being and live their life to the fullest. So that's still in the background. I shared this last time just to show you the degree to which whole health is spreading across the country in the VA. What I'm going to talk with you about now is the outcomes specifically from 18 VA medical centers, 1 in every region of the VA, where whole health has been implemented on a larger scale in response to legislation that was passed in 2016 that charged us with examining what it looks like when veterans with chronic pain have an opportunity to experience the integrative health or whole health approach. The outcomes of these 18 flagships, which is what we call them, were studied by a wonderful group from a VA Office of Research and Development, and I'm very grateful to them and their work, led by Barbara Bocour. So I'm going to share with you some of the results now, basically. The first thing we looked at was utilization. So at these 18 sites across the country, 31% of veterans with chronic pain engaged in some kind of whole health service across the first 2 years of this 3-year initiative. And the reason that was very important to us to measure and demonstrate is that we needed to know if whole health and the integrative approach to pain care is something that veterans are really interested in and will really participate in. One can't proceed with empowering and equipping unless the patient, the person whose life it is, wants to join in that. So I think this data showed us that absolutely there was a huge amount of uptake, and people were very open to participating in this approach. So what did we find? We looked at veteran impacts on a number of levels. I won't dwell on this slide because I'm going to talk about these in detail, but basically a number of positive impacts on veterans who are using the whole health system. And what I do want to share is this data comes from a patient-reported outcome survey, which we are sending out to, it will be 24,000 veterans by the time we're finished. Basically, they fill out the survey at baseline, they do it at 6 months and 12 months, and it's a compilation of a number of validated measures looking at how the experience of whole health is impacting all kinds of dimensions of their life. So when we talk about veterans participating in whole health for the purposes of this survey, this is what we're looking at. As I talked about last time, there are 8 evidence-based complementary integrative health approaches that are part of VA medical benefits now. Chiropractic care is also included. And then there's what we call the core whole health services, things like health coaching, peer-led pathway groups, educational groups, kind of the self-care and self-management part of the system. And the way we looked at the data is we said under 2 visits doesn't really count as whole health impact. Between 2 and 8 is some, and 8 or more is what we called comprehensive. So what did we find? Basically, as you move to the right in these graphs, you move to the more comprehensive users of whole health, as in 8 or more visits. This looks at the average opioid dose in morphine milliequivalents of veterans across a year of this program. The left-hand bar, which is black, shows you a decrease in 11% in the average dose for veterans across the course of that year. Of course, VA, like many other systems, is working on curtailing opioid prescribing, so not surprising that across the board we see a reduction. But when you move to the right, and particularly into the comprehensive users, you see a 38% reduction in average dose of morphine milliequivalents over the course of the year. So we're able to say that veterans who participated in whole health at a substantial level had 3.5 times the decrease in opioid use as opposed to veterans who did not participate. Now, again, I do need to share this is not a randomized study, so this is an observational cohort study. Clearly, there could be confounders. We can't necessarily prove that this is cause and effect, but we see so many correlations between whole health engagement and different aspects of improvement in the veterans who participated that we feel pretty confident that we are talking about a causal connection here. So on this slide, I want to bring your attention to the 2 far right columns. This is something called the Life Meaning and Purpose Scale. And basically, are you finding meaning and purpose in your life? And you can see that the comprehensive users, again, showed substantial positive movement on life meaning and purpose. So why is this important? Number one, this is one of the core concepts of whole health, that we're helping veterans focus on what matters to them in their lives. And this is a good sign that we're moving in the right direction. Number 2 is that veteran suicide continues to be a huge concern. And we know that loss of meaning and sense of purpose in life is a risk factor for suicide. So if we're able to improve the general sense of meaning and purpose for our veterans with the whole health system, that potentially becomes a way to approach, or one of the ways we can approach reducing veteran suicide risk. On this one, I want you to pay attention to the third from the left. This is the perceived stress scale. It's a 4-item scale looking at how much in or out of control did you feel of your life over the last month. And again, you can see the more whole health use, the more positively the movement on that scale. So we're giving people a sense of control of their life, a sense of being able to handle the stress that life is bringing them. I'm not going over every single one of these results. There are too many. But this whole report is available actually on the VA website, on our website, which is va.gov/whole health. And you can read the white paper, which describes all these findings. On this slide, I'd like you to look at the right-hand column, which is help with goals. This is a scale called the Goal Attainment Scale. And basically it looked at, did VA help me move towards the goals that were important to me? Not a specific goal that we had set, but a goal that the veteran themselves had put out there. The idea being that's what's important, of course. And again, you can see really substantial positive movement in the comprehensive users of whole health towards being able to attain their goals. And as I said, I think previously, this is a approach to care that requires active engagement. It requires people to make their own changes in their lives. And that's at the core of how we expect this to work. So to be able to see that, in fact, that's the way veterans are experiencing it, I think gives us a really positive a sign that we're moving in the right direction. We also looked at the impact of employees in working in an environment where whole health is being practiced. So there are sites that are doing a lot of it, sites that are doing less. Some of the employees in those sites are more engaged and some are less. And so looking at clinical staff, so physicians, nurses, all of the clinical staff in the flagships, we asked them, how involved are you with whole health in your site? 0 to 7, 0, not at all. 7, I'm the main organizer in my site. So basically what we found is that the more involved people are with whole health at their site, the more positive the outcomes they show on the all-employee survey. They're more likely to identify VA as a best place to work, more likely to report intrinsic motivation to do their job, more likely to report lower burnout, and also lower turnover intent. So all these things point in the direction of a really positive impact, not just on veterans, but on employees from the deployment of the whole health system. That's all I have for now, and there are lots more results to share on our website if you're interested in the white paper. And from there, I'm going to hand it over to Friedhelm to talk a bit more about how the whole health approach integrates into the step care approach, which is the core of VA's approach to pain management. Over to you, Friedhelm.
Yeah, thank you, Ben, for that great overview about whole health and the Veterans Health Administration in the US. I'm going to talk a little bit more about the outcome measures that we have for pain management. We've shown this before. This is a step care model for pain management, and you're certainly quite familiar with this by this time. But I want to emphasize again that it's so important that we have access to the integrative health modalities, as well as behavioral therapies and restorative modalities such as physical therapy, right within the primary care setting. And as we understand whole health and integrative health as a foundational setting, it's important that providers have access within the primary care to coach their patients and direct them and support them to get engaged with whole health, and also bring this in. It's part of the armamentarium as veterans come with their pain care needs to them. So this is a step care model for the VA. And again, we have integrated behavioral health and CIH modalities and rehabilitation modalities, which is our medical home, and we call that the patient-aligned care teams, the PAQ teams in primary care. And those are well supported by more specialized approaches within the specialty care setting, but really using the same approach. So I just want to go back to an analysis, which is really for all of the veterans who are engaged in primary care between 2010 to 2015. And what Dr. Frank and his team had looked at all the veterans who had a chronic pain condition. And you see the outline on the left side. They are primarily musculoskeletal pain conditions, back pain, neck pain, joint pain, and to a much lesser degree, migraine, neuropathy, and fibromyalgia, but also the high frequency of mental health comorbidities. About almost 20% have depression, 10% anxiety, and PTSD was diagnosed in 14% of these patients. And you also see that about 10% to 15% actually have a use disorder, with the most common one, alcohol use disorder. But clearly, over time, from 2010 to 2015, there is, and let's point that out first, in this light green, which is a long-term opioid therapy, a marked reduction in the reliance on opioids long-term. And I will talk about that in a moment, just a little bit more. And at the same time, since 2010, gradually increasing, there's a greater reliance or utilization of physical therapy and OT, as well as psychosocial treatment. So those were specifically measured here. And you can see that all these trends seem to accelerate around 2013, which is the time when we initiated the Opioid Safety Initiative in the VA system-wide. A little bit more about our opioid related measures. As I said, the Opioid Safety Initiative was started or went nationwide in 2013. And this is just a comparison of how much opioids truly have reduced since then. So overall opioid prescribing has gone down by about 64% from the last quarter in fiscal year 2012 to the most recent one that we have data for, which is Q3 fiscal year 2020. So that means that it ended at the end of June 2020. And you can see that there has been a 64% reduction of opioids overall, but the trend is even more striking if you look at the high-risk situations. Opioid and benzodiazepine co-prescribing has reduced by 87% over the same time frame, as well as long-term opioid therapy and high-dose opioid therapy has been reduced by 80%. And I just want to put this back here in a correlation. So this isn't just a reduction of opioid prescribing. At the same time, there's increased utilization of the non-pharmacological therapies. And in this study, which is really a follow-up study from Dr. Frank that I showed earlier, they looked up and said, I looked further and they said, okay, using physical therapy more, using CRH modalities more, what difference does that actually make on our opioid prescribing for in the subsequent year? And what they showed here is that the more these modalities, these non-pharmacological modalities were available at a facility and the more they were utilized, the less likely a patient presenting at that facility with a pain condition would be started on an opioid medication in the next year. And this is really interesting insofar as we can show that this is for physical therapy and occupational therapy and for CRH modalities on the left side. And as you can see, if you're in the highest percentile, which is a Q4, where this is being utilized, then the reduction of opioid prescribing is the greatest. It's also true for access to specialty pain care and somewhat less for psychosocial treatment. But there is really not a good correlation in that regard with non-opioid pharmacological therapy. In fact, a facility that relies a lot on medication will eventually probably use what looks like here actually opioids more. Now, as we implement all these changes in the VA system, it is so important that we obviously educate our providers, educate our patients, and most importantly, that we all use the same language, that we have a consistent communication that goes across our network, and that includes primary care, specialty care, as well as all the supporting staff. And what we have in the VA system there is what we call our academic detailing service, which are really pharmacists specifically skilled in communication, and they really form a relationship with our providers. They have multiple campaigns going on, opiate safety, pain management were one of the first initiatives and campaigns that these pharmacists have taken on, but it really has expanded now into a much broader array of many different, topics within our specialty care setting and our, and as relevant for primary care providers. And I'm bringing this among others to you because this is a publicly available website, and these resources, these handouts, as well as these educational tools, flyers for patients, they're all available to you and you can obtain them. And with this, I will hand it back to Eric, and I really appreciate your attention. Thank you.
Thank you, Friedhelm and Ben. And now I'd like you both to come on and join in a question and answer period, if I might. I want to say I would truly appreciate your focus on the team approach and the centeredness on patients and the individual pain sufferer. Ben, let me just ask, does the Whole Health Project follow a strict implementation model, or is there a latitude and flexibility across different regions of the VA, or accommodating, different demands and resources?
I think there's a lot of flexibility and individualization, let's say, of how the whole health system is applied. There are kind of the basic elements of the framework, as in availability of some of the integrative health modalities, emphasis on contact and community with veteran peers and coaches, and certain elements of the system that we are seeing applied across the country. But exactly how they're applied really has a lot of variety. And if you think about it, that makes sense. There are cultural differences. There are differences in the veteran population and demographics across the country. And the whole idea of whole health is really to make it work for the individual veteran. And then I think the other part of this is that within any given VA, the goal is to allow the engagement with the whole health system to really be highly individualized. What's important to that veteran, what matters to them, how is their pain impinging on their life, and what kind of resources can they bring to bear to help alleviate those problems. And so really it's meant to be a highly individualized approach to engagement with the veteran, I'd say.
Thank you. Friedhelm, as the ranks of women veterans grow within the U.S. veterans community, are you seeing differences in how women respond to treatments for pain than men? And if so, are there any best practices that we should be aware of?
It's really important to look at the difference between men and women and address those specifically for their needs, right? As we've pointed out, women have a higher prevalence for chronic pain, especially also for severe pain. When we had our National Health Interview Survey, it's a United States survey that was published in 2017, there were 9% of men who had, US veterans who were men had not had severe pain, and it was 11% in the women population, and both were higher than in the non-veteran population. But we also know that they have a higher psychosocial comorbidities and psychiatric comorbidities. But in regard to treatment outcomes, there are really a few changes as well. So we know that specifically about opioids, women have a history of being started less on opioids, but often when they're on opioids, more in the context with other, potentially dangerous combinations such as benzodiazepines. We also know that they seek more non-pharmacological treatment than men, and we also have some evidence that shows that they had actually, at least in the more traditional pain settings, lesser benefit long-term from our pain treatment. So really there are significant differences, and we need to address those, I think, in this context.
Thank you. We have just a short time left, but both of you stressed the continuity and the need to be following long-term the progress of our veterans as they're receiving care. Can you tell me about the importance of the change in the dialogue that's taking place between the care providing team and the veteran around the impact and the nature of pain and how it influences their lives? And I'll turn this to both of you.
So maybe I get started first, and then Ben, you can, chime in. But clearly, I think within our pain clinics, I think with our more traditional treatment settings, we've moved away from the numeric rating scale. We have not eliminated it, but we are de-emphasizing that. And it's much more about, what is the functional capacity? We also moved away from asking, what is it that you cannot do because of pain? We rather ask about what can you do with pain, right? How are you coping with it? It really is on the abilities and the function. And I think, the Defense and Veterans Pain Rating Scale that asks specifically about the interference with mood, the contribution to stress, and obviously the interference with activity and sleep is really what brings us to very core elements of quality of life. And that's really what it is among others. It's talking about how can you lead a high quality life despite the pain. But maybe Ben, you want to chime in? We have maybe just a couple minutes more.
I think we have very few seconds left, but Ben, if you have any final comments on that?
I think the core concept is this phrase, what matters most to you, what matters to you. And the whole orientation of whole health is to really put that question at the center of the conversation. And that's not something we're accustomed to doing in healthcare. And I think in some ways that really sums up the whole shift we're looking to make. It's a long-term relationship, it's a team sport, and it's really all about what's most important to the veteran.
Thank you. Thank you both. And I see my colleague, Lieutenant General Maisonneuve, has come up. Michel, it's yours.
Merci, messieurs, pour cette présentation et vos réponses aux questions de notre auditoire. Il est évident que l'utilisation d'un modèle de traitement multidisciplinaire a un effet très positif sur les vétérans souffrant de douleurs chroniques. Votre présentation démontre bien l'importance de soins complémentaires pour la douleur chronique et de l'implication des vétérans eux-mêmes dans leurs soins. J'aimerais maintenant vous présenter notre deuxième conférencière. Dr. Eleni Hapidou is a psychologist who has dedicated her career to working with veterans and others who suffer from chronic pain and experience difficulties coping with their life. She has worked at the Michael G. DeGroote Interdisciplinary Pain Clinic for 29 years, and this clinic is alongside the Chronic Pain Center of Excellence. Dr. Hapidou's work involves assessment, consultation, treatment, supervision, teaching, research, and program development. She's also a trained yoga teacher and teaches yoga to her patients as part of their treatment. Dr. Hapidou will be accompanied by Conrad Hiegsma, a veteran of 29 years in the Canadian Forces Armored Corps, who suffers from chronic pain and has been a participant in the multidisciplinary treatment provided at the clinic. Je vous rappelle que vous pouvez poser vos questions pendant la session en vous assurant d'être inscrit avec le panneau à droite et en soumettant vos questions par le même moyen. Dr. Hapidou, à vous.
Good afternoon, everyone. My name is Eleni Hapidou. I'm a psychologist at the Michael G. DeGroote Pain Clinic, and I'm here to present to you today some results that we have from our clinic. And this is from a study that I did with one of my undergraduate students, Jane Jomi. And just to also let you know that this study was published online at the Canadian Journal of Pain this past August. So more information you can find in the published study. I am here also with Conrad Hiegsma, one of our participants, veteran participants in our chronic pain program a couple of years ago. And Conrad will also share some of his insights about the program as we move on through this presentation. Among Canadian veterans, 41% experience constant chronic pain and 25% report interference of pain in their lives. For our particular study, we used archival data and we investigated 68 veterans matched for age and gender with 68 non-veterans. All our participants completed the 4-week Michael G. DeGroote Pain Clinic, the intensive chronic pain management program. The objectives for our study were to investigate the effectiveness of the Michael G. DeGroote 4-week program overall for all our patients who participated in the program, and to investigate differences in the pain experience between veterans and non-veterans. The hypotheses, again, were that both veterans and non-veterans were expected to demonstrate an improvement in their scores on these psychometric measures at discharge. And the veterans were expected to present higher scores on psychometric measures at admission due to their greater pain-related symptoms, as outlined in the introduction. So I would like to show you some of the demographics now. And as I said, our participants were matched for age and gender. So as you can see, the age is almost identical. You can see here information about years of education, years since they were employed last. And what I would like to point your attention to is the highlighted part, years since pain problem began. And as you can see for the veterans, 16.76 years versus 5 years for the non-veterans. It was often the case that our veterans told us that they began to experience pain right from their training, right after they entered the military and they were undergoing their basic training. Yet they tolerated this pain. They tolerated the problems related with pain for many years before they finally began to receive treatment and before they came to a program. And I'm wondering whether, Conrad, you might be able to contribute something to this as well.
Speaking for myself, I've been living with some degree of chronic pain since I was 21 years old. And I'm now almost 55, so it's been a long time. The first injury I had was a hockey injury to my lower back, and that problem persists still today. So I've been living with it my entire adult life, and actually right now it's fairly high level. I find that this time of year I have a lot more pain than I normally would because of the changes in weather. So my back has been flared up like it is now for approximately 3 weeks. And I'm seeing physiotherapy, I'm going to a chiropractor, I'm getting acupuncture, I'm trying everything I can. Yeah, but basically it's my sacroiliac joint on my right side, it's locked up. And it just doesn't want to stay loose. I'll get it loose for a while, it'll tighten up again. Mm-hmm. So yeah, I've been living with it pretty much my entire life.
Mm-hmm. Thank you, Conrad. Just continuing speaking about our demographics. We had our veterans who were exclusively veterans, and then we had our non-veterans that the group was made up of people who had their injuries and their chronic pain due to different reasons. So different referral sources. Motor vehicle accident insurance was the majority of our patients. Our workers' compensation, we had a few patients, as well as we had patients with no particular funding. These were individuals that their pain developed over a period of time, and they were more or less pro bono in our program. Moreover, I would like to point out your attention to the fact that a great number of our veterans, 63%, had a diagnosis, features, or query PTSD, and almost half of the patients who were non-veteran also reported PTSD. Just moving on with the particular results of our study right now. And I will present to you a number of different psychometric measures one at a time, and to show you the differences that we found between our veterans and non-veterans, but also to point out that overall, our program was found to help everyone. However, veterans were found to make greater improvements, greater changes as compared to non-veterans on a number of measures. So here, this measure is called recent bothersome symptoms, and it refers to a number of 25 different types of symptoms that people may have been bothered a lot in the past month. And so recent bothersome symptoms were reported to have decreased a lot more for veterans than non-veterans. And where you see the asterisks, this indicates that the change is much more significant for the veterans compared to the non-veterans. However, both groups decreased significantly, except the veterans made a greater change. In terms of kinesiophobia, or fear of pain, as you can see here, again with the asterisks, the veterans improved a lot more than non-veterans in terms of reducing their fear of movement, their fear of re-injury. Moving on, showing you more results. On depression, everyone in the program improved in the same way from admission to discharge. As you can see here by the session effect, session refers to differences between admission and discharge. So both veterans and non-veterans made significant reductions at discharge. And I'm wondering, Conrad, at this point, whether you would like to express some of your own insights about this as well.
The experience of the program gave me the tools to better deal with the anxiety and the depression both throughout the program, through the different types of therapy and stuff we did and the classroom work. So basically all the tools combined definitely helped to improve the anxiety level.
Mm-hmm. Mm-hmm. Okay. Thank you, Conrad. With regards to pain catastrophizing, again, you can look at the asterisks here. We have a little bit more of a complicated picture for this particular slide, in that, as you can see here, both groups decreased from admission to discharge in terms of the session effect. And there was a group by session interaction, which meant again that our veterans did better than our non-veterans, even though both groups made a change at discharge. And one more difference that we found here with post hoc tests is that our veterans had lower scores on catastrophizing at discharge compared to the non-veterans, even though both started at about the same level. Continuing with anxiety, there were significant session effects, again, differences between admission and discharge for both groups. However, the significant group by session interaction indicated that only the veterans made greater reductions in their anxiety at discharge compared to the non-veterans. And again, Conrad, I would be very interested in your insights about this as well.
So I suffer from anxiety and depression, and I also quite often would catastrophize my pain, thinking that it would never go away, it would get worse. So through attending the DeGroote Pain Clinic and also seeing my therapist, I've been able to get a much better hold on it now, and I'm able to deal with it much better than before. And so within the 4-week program, I found significant difference in both the anxiety and depression.
With regards to pain interference or pain-related disability, both groups, veterans and non-veterans together, decreased their disability scores at discharge. There was no significant interaction effect here, but both of them had lower scores at discharge as opposed to admission. Pain acceptance. There were significant group and session effects, no interaction effects. So basically what this meant is that there were significant differences between the groups. And there were also significant differences between the sessions, between admission and discharge. There were a number of pain coping measures that were looked at as well, but here I will only talk to you about one of them. And this is called task persistence. Task persistence is viewed as an adaptive coping strategy. Ideally, we would like it to increase in chronic pain management. Again, this is paradoxical, what I'm going to tell you right now, because our veterans came in with a much higher task persistence than non-veterans, and they reduced it at discharge. Now, we consider this change to be adaptive for our veterans. And for some informal conversations that I had with various people, they told me that because of the culture of the military, veterans are very persistent in completing their tasks, pain or no pain, symptoms or no symptoms. So the fact that our veterans were able to decrease their task persistence in the program, we consider it to be an adaptive change. Overall, I would like to indicate to you all the different percentage of changes that people made in the program, whether they were in both groups actually, but particularly with veterans. They reduced their catastrophizing by 47%, their depression by 40%, their kinesiophobia by 32%, anxiety by 30%, recent bothersome symptoms by 26%, pain traumatization by 18%, and pain disability by 14%. There was also a 5% reduction in pain intensity, but this was not significant. They also increased their chronic pain acceptance by 30%. Now, in terms of the program evaluations of our patients and their case managers, I wanted to just talk to you a little bit about a couple of measures that I developed of the program over the years. One of them is called patient self-evaluation and case manager patient evaluation. And this measure goes from 1 to 5. 1, poorly, 5, excellent. Patients are asked to indicate to what extent they feel that they have accomplished their goals in the program on this scale. And their case managers are also asked the same question about their patients. So as I said, it goes from 1 to 5, and our veterans evaluated themselves higher than non-veterans in terms of how well they felt they accomplished their goals in the program. Similarly, their case managers evaluated them the same way. So the case managers of the veterans evaluated the veterans as having done better in their goal accomplishment compared to the non-veterans. However, our veterans and non-veterans were no different at all in terms of the changes that they felt they made in improving their physical, emotional, mental, and social domains. However, when it came to their case managers' evaluations, the case managers evaluated their patients higher in all of these domains, physical, emotional, mental, and social improvements, compared to the non-veterans. So, to summarize our hypothesis, both veterans and non-veterans were expected to demonstrate an improvement in their scores in the various psychometric measures at discharge. This hypothesis was supported because significant improvements were made in depression, pain-related disability, pain acceptance, sensitivity to pain traumatization, stages of change, and a number of pain coping domains in both our groups. Second hypothesis, that the veterans were expected to present higher scores on psychometric tests at admission due to greater pain-related symptoms, was not supported. Even though veterans and non-veterans were comparable at admission, significant differences in improvement due to the program were observed. Veterans experienced significantly greater improvements in anxiety, pain catastrophizing, recent bothersome symptoms, fear of pain, task persistence, and the pre-contemplation and action stages of change compared to non-veterans. So in conclusion, our study provides evidence for the effectiveness of interdisciplinary pain management programs in addressing chronic pain and related comorbidity in veterans and non-veterans. The unique aspects of pain experience among veterans were identified, thus helping clinicians to offer better informed approaches to pain management for this population, this special population, and so improving the lives of veterans and their families. To understand the long-term effects of pain management programs on veterans, chronic pain, a long-term follow-up study is currently underway. Thank you very much for your attention.
Merci beaucoup, Docteur, pour cette présentation. Dr. Hapidou wants to say a few words before we move on to questions. Eleni?
Thank you very much, Michelle. I would like to thank Conrad for your gracious participation and sharing of your valuable insights today. I would also like to thank the Center of Excellence for including us in this series of talks, especially Dr. Zacharias, under whose leadership and vision we have this Center of Excellence. Finally, I would like to thank my teammates at the PAIN program and my students, especially Jane Jomi, with whom I did the study, as well as all of our patients who put their trust in us to work together to help them in their health and rehabilitation journey. Thank you all very much.
Merci beaucoup, docteur. Thank you very much. Alors, votre présentation démontre bien les effets positifs d'une approche multidisciplinaire pour le traitement de la douleur chronique. De plus, Conrad a bien expliqué l'effet bénéfique sur la douleur dont il souffre, lui, personnellement. Thanks to you both for your presentation and for your research, which actually shows that there is indeed hope for improving the lives of veterans suffering from chronic pain and their families. We'll now move on to the questions posed by you, the audience. First to Eleni. I mentioned that at the pain clinic, you're the psychologist, but also the yoga instructor. Can you discuss how yoga has impacted veterans with chronic pain and whether you consider yoga a part of a multidisciplinary approach to pain management?
Thank you very much, Michelle. I appreciate this question. I would like to talk about yoga a little bit. The intention of yoga is to cultivate mindfulness through a combination of physical movement, poses or asanas, breathing exercises or pranayama, and intentional relaxation such as yoga nidra. The practice of yoga has shown benefits for many medical disorders such as heart disease, hypertension, chronic pain, and insomnia. And yoga has become one of the most widely practiced forms of complementary medicine and healthcare in the US and Canada and overall in the Western world. Yoga is linked to the alleviation of depression, anxiety, eating disorders, ADHD, and even schizophrenia. Focused breathing is associated with emotion regulation and sympathetic nervous system functioning. Meditation is associated with reduction of anxiety and depression. Moving one's body alongside others is associated with increased feelings of interpersonal connection. And the physical benefits of yoga in terms of reduced muscle tension and pain can address somatic complaints. And last but not least, biochemical and physical changes and increases in GABA and decrease in catecholamines and beta cortisol levels can help fight against stress. So all these benefits of yoga are applied to our program through regular practice, as well as encouragement of regular practice of certain asanas, certain movements following participation in the program. And our veterans, as well as our non-veterans, all participate in our yoga sessions and report on the positive effects. Now, I do believe that yoga should become part of all multidisciplinary approaches to pain.
Thank you very much, Eleni. That's very, very interesting. Now a question for Conrad. You said you've been suffering pain since you were 21. Can you detail a little bit when you joined the multidisciplinary program, i.e. how long ago, and how did your mindset change as you progressed through the program?
Okay, it was about 3 years ago now, I guess, approximately, when I was basically at a point in my life where I was almost ready to give up. If I was to go to sleep and not wake up the next day, I'd be perfectly fine with it because I just couldn't deal with the pain any longer. So attending the DeGroote Pain Clinic was the best decision I ever made, because being associated with other people, different walks of life, with something so profound in common with living with chronic pain, it kind of made me feel like I belonged there. And I hadn't felt that way since my release from the military. And I can, speaking of what Dr. Hapidou just talked about, I've been a regular participant in yoga ever since I've come back. And it's made quite a difference as far as my flexibility goes and whatnot. It's not going to fix everything, but I would say that you have to have an open mind coming into the program, that a combination of the social aspects and the multidisciplinary events that you go through while in the clinic combined makes such a huge difference in my life. And I honestly don't know where I would have been if I didn't attend.
Thanks, Conrad. Eleni, back to you. In your presentation, you explained that veterans are more likely to suffer in silence, that their tolerance of pain seems higher than the norm. So why is chronic pain in veterans so particularly challenging to deal with?
Yeah, thank you, Michelle, for this question. Indeed, veterans have a very complicated presentation. From a US survey, we know that 50% of male veterans and 78% of female veterans report chronic pain. And I've already spoke about the statistics in Canada. Not only do veterans have a higher prevalence of chronic pain, they also report higher rates of severe pain. They also have more comorbidities, as it was mentioned by one of the previous presenters who talked about depression, PTSD, and anxiety being reported by 19%, 14%, and 10% of veterans respectively, along with their back and neck pain. 50% of veterans with PTSD also report chronic pain. So indeed, this makes for a very complicated presentation, and many have PTSD and childhood abuse in addition to chronic pain as well. And the rates are higher than the general population. And of course, we cannot not talk about the opioid crisis and how that affects veterans as well. So in terms of our program, our veterans wanted to continue their military career and were very upset to be medically released. It was not their choice. So adjustment to civilian life is often a significant issue for our veterans. And I also always remember a movie, The Hurt Locker, with Jeremy Renner, who could not adjust to civilian life and went back to the field as well. So that always comes to my mind. I spoke about task persistence in our veterans and the fact that they started with a much higher level when they began the program, and they reduced significantly at discharge. Our veterans have the need to complete tasks irrespective of pay due to their military training and their mentality. So our reduction in task persistence at discharge is a positive and adaptive change, and perhaps we need to change the way we look at task persistence in the coping questionnaire, but I'm pretty sure that Conrad might also have his insights about the increased pain tolerance in veterans as well.
Thanks, Eleni. Thank you very much. In fact, I'd just like to ask Conrad to say one quick statement here. And if he had a chance to speak to other veterans about the pain programs, what would you like to share with them, those of them who are watching this in a couple of seconds, please?
So I would say to have an open mind with regards to different methodologies to deal with your chronic pain, because the human body was made to move, and you just have to keep moving. In addition, thank you for attending today, and good life with your journey to better health. Thank you.
Thank you. Merci beaucoup, Dr. Hapidou et Conrad. Thank you, Doctor, for your passion for helping veterans who experience pain. And Conrad, thanks for your service to our country. I'll turn it over now to Dr. Schoolmaker for closing comments. Eric?
Thank you, Michelle, and thank you, my fellow general officer and in an allied force, for your enduring leadership and service to your nation and to your veterans. I want to, in closing today's session in this weekly series of 4 sessions, I want to thank Dr. Zacharias and the team at the Chronic Pain Center of Excellence at Hamilton, the Wasserman team and their roster of really talented athletes who have made this a remarkable professional experience. But I really want to thank our audience for joining us. I hope you see that our commitment to relieve the pain and suffering of our U.S. and Canadian veterans is deep, it's profound, and it's enduring. I sincerely hope that you'll engage in taking advantage of the many resources and the caring teams that we have highlighted during this series, and that your burden of pain can be lifted in some fashion. Thank you all. Back to you, Michel.
Merci beaucoup. Alors voilà, nous sommes arrivés à la dernière session de notre série de 4 webinaires qui avait pour mission d'aider les vétérans qui souffrent de douleurs chroniques. Il ne reste qu'à vous dire merci pour votre présence et vos questions. My thanks to the entire COE team and to Wasserman for putting on these webinars. As we hope was evident in the webinars, veterans can get services and there is hope that your pain can be managed. Before I turn it over to Dr. Zacharias for final comments, I want to highlight the excellent collaboration with our U.S. colleagues. It is a privilege and an honor to collaborate with Lieutenant General Schoolmaker and all our colleagues in the U.S. in order to help veterans for both our countries. We have fought for our freedom and our values alongside each other in the past, and the fight continues today to ensure our veterans receive the best care possible. Merci beaucoup à tous et au revoir. Dr. Zacharias, à vous.
On behalf of the Center of Excellence, thank you to all of you who have joined us today. De la part du Centre d'Excellence, merci à tous de vous être joints à nous aujourd'hui. To General Eric B. Schoolmaker, General Michel Maisonneuve, and all of our speakers, we truly appreciate the participation in our symposium and your tireless efforts to improve the well-being of our veterans and their families. Au Général Eric B. Schoolmaker, au Général Michel Maisonneuve et à tous nos conférenciers, nous apprécions vraiment votre participation à notre symposium, ainsi que vos efforts constants pour améliorer le bien-être de nos vétérans et de leurs familles. The Veteran and Family Wellbeing Series has now concluded. Thank you to all of you who have joined us over these last 4 weeks. La série sur le bien-être des vétérans, de leur famille, est maintenant terminée. Merci à tous ceux qui se joignent à nous au cours des 4 dernières semaines. Merci à tous et je vous souhaite une bonne saison des fêtes. Thank you all and hope you have a safe holiday season.